Again.
Hello to everybody. I'm proud to make this webinar about MPS and early signs and to speak about the many different phases of this disease. I'm in Vienna in Austria and I say hello to all of you looking at this webinar. This webinar is offered by Excellence in Pediatrics Institute, and these are the notes for the attendees you can see later on. And these are my disclosures. I want to point out that the pictures of the patients were kindly provided by the Austrian Society of Mucopolysaccharidosis and Similar Disorders. And some of the pictures are out of the book Mucopolysaccharidosis, a guide for physicians and parents. I will speak about the mucopolysaccharidoses, what they are, what are mucopolysaccharides or the glycosaminoglycans, what are the early signs, and when should we think on MPS, and which tests should be performed, and why is it necessary to diagnose MPS so early. What are mucopolysaccharidoses? The first description of these diseases was in 1917, exactly 100 years ago. It was made by a Canadian medical doctor, Charles Hunter, and he described two brothers with the age of 8 and 10 years. And he just told it as a rare disease in two brothers. He did not know in any case what it is. If you look at these pictures of Charles Hunter, you can see that on the right side, two brothers living now have very similar gestalt, and these brothers suffer from MPS too, and they are 6 and 9 years old. Soon after description of Dr. Hunter, in 1919, there was this description of two boys by Professor Meinrad von Pfaundler and Gertrud Hurler. And Professor Pfaundler was working and living in Vienna and later on in Germany, and Gertrud Hurler was a pediatrician from Germany. And they described a paper about a type of multiple changes, especially in the skeletal system. And you see two boys, and the younger one, George, is about 3 years old. And you can see on the right side a boy with 3 years suffering from MPS 1. He looks very similar to this boy described by Pfaundler and Hurler. The X-rays from Gertrud Hurler she made were taken in a student's book in the 1940s, you can see here. And Professor Pfaundler used them to describe what is summarized as dysostosis multiplex. What is it? It is a sclerosis of the skull, especially of the basis of the skull, a G-shaped sella tristica, malformed vertebral bodies, especially in the thoracal and lumbar region. There are broad ribs and malformed metacarpalias, and all this together is called dysostosis multiplex. For decades, this disease was known, described as gargoylism. Gargoylism is the word for gargoyle faces, and the gargoyles are figures on the outside of churches, Gothic churches, spying water or not, and these figures had some similarity with the patients, but one did not know what the patients have. So these faces made them for a long time to be called gargoylistic patients or gargoylism. What are the mucopolysaccharides or glycosaminoglycans, sometimes called acid glycosaminoglycans? The mucopolysaccharides are these substances giving the disease the name. These are sugars, and these sugars are made in chains. You see such chains here, long chains, and they are bound to proteins, and we call them in combination glycoproteins or proteoglycans, depending on the predominating part. And the proteoglycans and glycoproteins are on each cell surface, as you can see here. They are called the glycocalyx, and have an interaction with the extracellular matrix or other cells, especially in the nervous system. In the extracellular matrix of connective tissue, you can find them in the skeleton, in joints and ligaments, intervertebral discs, heart valves and cornea. and they are responsible for the organ-specific consistency, the water content, and other characteristics. And so you can imagine that these substances and molecules are everywhere in the body, they are ubiquitous. The cause of MPS, one has to explain. We have a correct composition of the chains, first in the endoplasmatic reticulum and Golgi apparatus, and these chains, or shorter chains, are excreted and the composition is made to macromolecules outside the cells. But due to the aging and for renewing processes, you have a stepwise degradation, and this degradation starts outside the cells, and by endocytosis, these shorter chains are brought into the cells, incorporated, and brought to the lysosomes. And in the lysosomes, you have, these lysosomes are small cell organelles. In these organelles, you have a lot of enzymes, and these enzymes are important. These enzymes are gene products, and these gene products are made of proteins, and these proteins are formed in the ribosomes and some sort of modified in the Golgi apparatus. They get sugar chains and such things, and they get also a special marker, the mannose 6-phosphate marker. And this mannose 6-phosphate makes them ready to be brought to the lysosome, and in the lysosome they are incorporated, and there they are responsible for one degradation step. And if you have many enzymes, you have a lot of possible degradation steps you can perform. In the mucopolysaccharidosis, you need 11 enzymes which are involved in this degradation process of these sugar chains. And the cause of MPS is that you have gene mutations causing defective enzymes in these diseases. Here you see the sugar chains, and these sugar chains are modified glucose and galactose, and they have sulfate groups or N-acetyl groups, and these different compositions makes them that we call them chondroitin sulfate or heparan sulfate or dermatan sulfate or keratan sulfate or hyaluronic acid. And sometimes at the end or side chains you have other rare sugars such as mannose or fucose. And you have a stepwise degradation by 11 different enzymes, and all of these enzymes remove, for instance, one sulfate group or N-acetyl group or one of these sugars. And so you have a stepwise degradation, and if you have only one enzyme deficient, all the others increase and are stored, and the next steps cannot be performed. So you have a blockage in this degradation process, and the non-degraded material is stored. Mucopolysaccharidosis are storage diseases of that non-degraded material. This material increases continuously in the lysosomes and in the cells and organs, and you can see it. In the light microscope, you see, for instance, in the leukocyte, the small white vacuoles. These are filled up with glycosaminoglycans. Or in the electron microscope, you can see that the cells are full of such lysosomes, full with stored material. And if this cell die, these glycosaminoglycans, this material, comes into the blood and into the urine, and you have an elevated excretion of the urinary guts. And this is specific for all MPS types. So if we say, what is the cause of MPS? MPS are caused by inborn metabolic disturbances in the degradation process of these gut chains due to defective enzymes. Now we have a big group of MPS. We have 11 types, we have 11 defective enzymes, and we have 11 genes we know so far, and these are all the gene loci you can see on this table. What are the early signs? That is difficult to describe, because MPS diseases are diseases with increasing symptoms and signs of storage, and therefore at birth all the children look healthy. If you look at these children when they develop the next months and years, they have increasing symptoms, but these symptoms are very heterogeneous, and they can involve many organs in different combinations, and so they can vary from very severely affected patients to attenuated forms in the adult patients. And therefore, at the beginning, you have early signs, but they are very unspecific. At birth, the children often look taller and heavier than the average. They have a relatively large head. They have dysplasia of the hip joints. They have often catarrhal infections of the upper airways. They have snoring, breathing, an open mouth. They have repeated ear infections. They have fluid in the middle ears, so they need often ventilation tubes. And they have an overgrowth of the adenoids, and they have hernias, inguinal and umbilical hernias. But if you look at all these symptoms, you would say, I have a lot of children I have care on, and many of them have these signs, so they are very unspecific. Other signs can be unspecific, but it really can show you that there is something wrong. It is a slowing down of the growth, so it results in a disproportionate short stature. Still, they have an enlarged head and perhaps frontal bossing and dolichocephaly. They can develop a midface hyperplasia with a saddle nose. They have thick and bulging lips and enlarged tongue, and they need operations of the adenoids and the tonsils, and they develop distinct dysmorphic features. Very special is that they develop contractures, and especially in the shoulders and in the fingers and hips and feet. And they can show chest deformities and bushy eyebrows with a stiff hair. But early signs which are really specific are if they develop hepatomegaly, splenomegaly, lumbar kyphosis, as you can see here, changes of the facial features, skeletal deformities, a language delay, a gingival hyperplasia or small and malposed teeth, disproportionate small size, and optional corneal clouding, cardiomyopathy, developmental delay or epileptic seizures. So you can observe a stop in the development and some sort of regression. And if you make an X-ray of these patients, here you see the radiological pictures, very similar to those I have shown before from Dr. Hurler. These patients have MPS, and these signs of dysostosis multiplex can be seen on the sclerosis of the skull basis with the G-shaped sella, on the malformed vertebral bodies, malformed long bones, malformed metacarpalias, or flattening of the femoral head. If we try to group MPS disorders, all these 11 MPS disorders, I would say one can make 3 groups. The group 1 is the classic type of MPS, and this means it is predominant storage. And under this group, I summarize MPS 1, Hurler's disease, MPS 2, Hunter's disease, MPS 6, Marutola disease, and MPS 7, Sly disease. But very different from this classic type, we have the skeletal types of MPS. These are the Morquio diseases A and B. And here you see predominant skeletal changes. And the group 3 is again different, and this I call the neuronopathic types of MPS. They have predominantly psychomotoric problems, and here we have the cenophalipid diseases type A, B, C, and D. If I start with the classic types of MPS, it is the disease where the storage dominates. You have the recurrent infections, upper airways and ears, inguinal and umbilical hernias, lumbar kyphosis, joint stiffness of the fingers. These are responsible for the special MPS fingers you have in the logo of these patients, and very early carpal tunnel syndrome. This is a very remarkable sign. Stiffness of all joints. You can see the shoulder is the maximum this boy can move, and the elbow is also the maximum he can move, and you have reduced movement You have hepatomegaly, sometimes hepatosplenomegaly. You have the skeletal changes, I have already told you, short stature, MPS-specific facial features, heart valve insufficiency, optional corneal clouding, and cardiomyopathy or psychomotoric retardation. And if you see this picture, you see a lot of these signs, perhaps you see from outside. The large head with the frontal bossing and the very deep nose here, the saddle nose. You see the different facial features. You see the large enlarged tongue. You see the teeth which are not okay, the lumbar kyphosis, the stiffness of the finger with the special hands. The patients are not able to hold anything really correctly. But you have a variability of the phenotypes, and on the left side you see severe forms of this disease, but you can notice that other patients do not really look so different. They can even have a normal size, but some of the faces are perhaps not as you expect, and they also have a milder form, an attenuated form of these diseases. The skeletal type, the second type, is very different. You have severe skeletal changes with short stature, very short rib cage here, and chest deformity, hip dysplasia, and flattening of the femoral head. And often these patients are called that they have Pertus disease on both sides. They have a laxity of ligaments, exactly the opposite of before, a laxity of ligaments, and this is responsible for a waggling gait with this genera valga and hypoplasia and aplasia of the dense axis, the second vertebral body. And they have progressing corneal clouding, hearing deficits, but they are very intelligent and have high, especially social competences. And here you see a lot of these symptoms. They do not look like storage disease. They have very severe skeletal problems with the knees, with the hips, with the thighs, and they have a lot of operations, and you can see when they are standing, it is really flat foot and hypermobility. And this special hypoplasia or aplasia from the second vertebral body is responsible that you have instability and a severe impression of the myelin. And here you can see severe forms. They start very early with operations, neck stabilization operation, leg operation, a lot of problems they have from the orthopedic side. But on the right side, you see a man who was diagnosed when he was 52 years old. He had a hip joint replacement operation, and some of the medical doctors thought on an MPS. It was an MPS 4A. So we have a third group, and this group starts really differently. This is the group where behavior problems, hyperactivity, and attention deficit dominates. And they have a progressive developmental delay. They have no language, or if they speak already some words, they regress and show regression and lose any language. They have loss of skills they have already learned, or they are toilet trained and lose it, or they are not toilet trained at all. They have sleeping problems, which is also the problem for the parents because they do not sleep at night. They have epileptic seizures, and in the progression of the disease, they lose everything, even the ability to walk, so they are wheelchair bound, and then even they are unable to swallow, to cough up. They have apneas and increasing paralysis. If you look at these pictures, you never would think on a gargoyle face. It is a very beautiful face all these children have, but they are very hard to care on because they are really bad children. They are, one says, if they come to a medical office, one never forgets it because everything was changed and nothing was on the place as it was before. They take everything in the hand, in the mouth, and so on. And they have very beautiful hair, but you see the thick hair. They have bushy eyebrows, you can see here, but they look very beautiful, and with the time they have the regression, are not able to walk any longer, and they are really very, very severe very severely sick patients. Here also you can see a variability. Sometimes it starts very early and you have all these symptoms even in childhood, but sometimes it is late. You see here a man looking really normal at the age of 28 years, but due to his mental behavior, he was diagnosed to have Sanfilippo. When should we think on MPS? As soon as possible, because we have therapeutic options. We have to accept that rare diseases are rare, but the disease of the whole group of MPS and lysosomal diseases is not so rare. So you should think on if you have disproportionate macrocephaly, if you have early carpal tunnel syndrome, if you have unexplained cardiomyopathy or a dysostosis multiplex, especially in the hips, and if you have an unexplained psychomotor retardation, think on MPS, and if you have language problems in your patients. And I discussed it with my colleagues, and they said, if you have an unspecific sign and another unspecific sign and a third unspecific sign, this makes it suspicious to have MPS at the beginning, and you should think on. That is really difficult, I can imagine. Which tests should be performed? The first is that you think on MPS due to the clinical symptoms. Then you make perhaps the radiological pictures and you see the features of dysostosis multiplex. You can look at the urinary gags, but I have to say they can be false negative in MPS 3 and MPS 4, but they also can be false positive, for instance, during infections or after operations. So you can look at the defective enzymes, and I have to remember that there are 11 enzymes which can be defective. And you have gene mutations in 11 possible genes. So one should think to perform perhaps a whole exome sequencing investigation. I am encouraging for a broad clarification, because it is not possible that you can say this is MPS type 1 or this is MPS 3A. It is impossible, even for me after so many years. But if you have some results, you always have to look, is it right? Are the clinical and laboratory results fitting together with the clinic of the patients? The genetic counseling for MPS is that all of them, except one type, it is MPS 2, all types are inherited in autosomal recessive trait. So you have carriers, they are healthy, they can be males and females, and they have one gene allele mutated. We call it heterozygous. And you have the patients, they can be males or females, and they have both gene alleles, these mutations. And if you have homozygous mutations, the disease is confirmed. If you have combined heterozygous mutations in the sequencing, then you have to prove that it is not in the cis, but in the transposition. It has to be confirmed, the transposition of the two different mutations on the two different gene alleles. The MPS 2 type is X-linked, and we call it X-linked recessive, although I'm not so sure if recessive is really true all the time. The carriers are always females. They have 2 X chromosomes and they are healthy, and they have one mutation on one of the 2 X chromosomes, and we call it heterozygous. The patients are always males, and we call that hemizygous if they have one mutation on the X chromosome. But I have written down that very rare you find females with this type of MPS, the MPS type 2, due, for instance, due to X inactivation of the non-mutated X chromosome. Why is it necessary to diagnose MPS so early? I think one of the main causes is to prevent myelopathy and tetraplegia due to the instability of the craniocervical junction. It is especially in MPS 4, but you can have it in a milder form in all the other cases. So first look if the dense axis have a hypoplasia or aplasia, and correct them by operation as soon as early to prevent this tetraplegia. The other cause is that if you find early enough patients with MPS I, you can offer a hematopoietic stem cell transplantation, and this disease or this treatment of the disease is now the gold standard for MPS I. But it must be before the 18th month, and this is very early. For many other patients, you have enzyme replacement therapy. This means a weekly intravenous infusion of the deficient enzyme. So the enzyme is produced and given to the patients every week. This is available for the patients with MPS I, 2, 4A, and 6, and it is planned in the next year for MPS 7. But there are a lot of multiple clinical trials with intrathecal and intraventricular enzyme replacement therapy, for instance, in the neuronopathic forms of MPS 2 and 3, gene therapy for the MPS 3 patients. All these difficult trials are because the intravenously given enzyme cannot come through the blood-brain barrier, and this is the reason why one has to take other ways to bring the enzyme into the body. We have trials with substrate reduction therapy, chaperone therapy, and read-through gene therapy in MPS I patients. For many patients, the enzyme replacement therapy is part of the daily life, and they can get it in the hospitals, but they also can get it in the doctor offices of pediatricians and other medical specialists. And here you see this patient gets this in the home therapy, and this is a very good way to have a lot of quality of life. Now I have shown you my presentation, and I live in Vienna. Perhaps Vienna is known, some of you, due to Mozart and Kaiserin Maria Theresia or Empress Sissi, and this is my place where I'm working on. Here you see a list of the webinars in other LSDs, and I want to mention that there are webinars about Gaucher disease, Fabry disease, and now also MPS disease you can see at any time you want. And now I am ready to answer your questions you probably have. I still wait for the first questions. Thank you that you have been going with me through that presentation. Oh, I see the first question. The first question is, if a newborn looks suspicious to have MPS due to hepatosplenomegaly and macroploxy and macrocephaly, shall I test for MPS? I would not think on MPS if a newborn shows all these signs. We have very severely affected patients, but this you can even recognize in utero. It means they are born with hydrops fetalis, especially in MPS 7 or 4A. But if a newborn looks very, very strange, I would think perhaps on Beckwith-Wiedemann or other diseases and not on MPS. It can also be a mucolipidosis type 2. That can be, but not MPS. Another question is, can I find pathological results in the routine laboratory tests, such as hypoglycemia or high bilirubin or anything else? No, these diseases are metabolic diseases, but not metabolic diseases of the nutrition. These are metabolic diseases in the cells, and therefore you cannot find anything in the routine laboratory results. The third question is, you told that MPS patients could be treated by hematopoietic stem cell transplantation. Until which age is this therapy an option? As I told you, the option is really good for MPS 1, perhaps for MPS 6 at the moment, but the transplantation has to be performed before the 18th month. So this is means that you need a very early diagnosis, often not done. It is not an option at the moment in MPS II, in Hunter's disease. It is not at all an option in MPS III, Sanfilippo's disease, because all these diseases perhaps have the problem with the blood-brain barrier, and this is also a problem even if you make a stem cell transplantation, hematopoietic stem cell transplantation. I do not have more questions. I thank you all for watching this webinar, and I hope that you have take the chance to look back to this webinar. You can find it as often as you want, and perhaps some of the pictures may be helpful in watching your patient and looking back. What did she say? What did she show to us? And I thank you very much, and I thank the organizers very much for the opportunity to make this webinar. Bye bye from Vienna. Bye bye.